So, good morning. We'll be discussing about quick revision series in medicine. Today's topic will be about the entire cardiology in short. So, this will be useful for competitive exams like NEET, INICET. Okay. So, we'll start our cardiology discussion. So, first about few basics. One is about the cardiac conduction system. So, we know very well the cardiac conduction system starts from the SA node, the right atrium, and the fibers from the SA node go to the AV node, and from AV node what originates is the His bundle, and the His bundle divides into two branches, the right bundle branch and the left bundle branch, and the left bundle branch divides further into left anterior fascicle and left posterior fascicle. This is grossly the conducting system. Remember, the impulses from the SA node directly depolarize both the atria. The SA node directly depolarizes both the atria. But the SA node, for the fibers to reach the ventricle, it has to cross the AV node. It has to go to the His bundle. It has to divide into two, and then only it can go to the right atrium or the left atrium. So, one important applied part here is from the SA node to the His bundle. This is how the vector direction goes. So just remember, the vector direction is 60 degrees. We will discuss it more detail when we come down. So just know this basic system. Now, something about the cardiac pacemaker potential. The heart has two types of cells. One is cardiac myocytes and another one is cardiac pacemaker cells. Myocytes are the ventricular cells which contract when stimulated. They do not have the property of automaticity. The cardiac myocytes do not have automaticity. But what about pacemaker cells? See, SA node is the major pacemaker. Of course, when SA node is dysfunctional, the other pacemakers like AV node etc. take over. But still, SA node is the primary pacemaker cell. What is peculiar about pacemaker? It has automaticity. That is, it can depolarize even without any stimulation. So it has automaticity and it generates its own rhythm. So we know very well the rhythm set by the SA node is around 60 to 100, which is the normal heart rate. Actually, the rhythm set by the SA node will be mediated by both sympathetic and parasympathetic activity. You can say the average SA node automaticity is around 70. Of course, in the absence of SA node, the other cells like AV node etc. also can function. For example, if AV node functions as the pacemaker, when SA node is dysfunctional, it generates its own rhythm around 50 per minute. When the ventricle generates its own rhythm, its rate will be around 40 per minute. So when the rhythm originates from ventricle, we call it as idioventricular rhythm. So we will be discussing more about this shortly. So just remember, what is important in the pacemaker action potential is the phase 4, because the heart cells spontaneously depolarize. What is important for the spontaneous depolarization is the funny current, IF current, which is a sodium channel. So when this funny current or funny channel allows sodium ions to enter into the cells, so that depolarization occurs from 60 millivolt to 30 millivolt. At 30 millivolt, other channels open, like the calcium channels, which help in depolarization. So this funny current or funny channel, you can remember, because one drug inhibits this funny channel. That drug is ivabradine. It's a funny current inhibitor, or it's a sodium channel inhibitor. When this funny current is inhibited, what happens? The SA node loses its automaticity, so its rate will automatically fall. So it is ivabradine can cause bradycardia. So remember the phases. There is phase 4, which is the most important phase, or the spontaneous depolarization phase. Think of the other phases also, phase 0, phase 3 and phase 4. Whereas compare this with the cardiac myocyte action potential, which has all the phases, phase 4, phase 0, phase 1, 2, 3 and 4. So phase 4 is the state of hyperpolarization or resting membrane potential. 0 is the phase of depolarization, which is caused by sodium channel. It is not the finite sodium channel which is present in cardiac pacemaker, it's the sodium influx. Once it depolarizes beyond a particular limit, the sodium channels close and potassium channels open. We know very well that when potassium channels open, potassium leaks from within the cells to outside, so it will try to depolarize the membrane again. So that is the phase 1, the initial repolarization. But what prevents this repolarization is calcium. So phase 0 is brought about by sodium, phase 1 is brought about by potassium, and phase 2 is the plateau phase, where calcium tries to come in to balance the potassium which is going out. So the ion which is very important for phase 2 plateau phase is calcium. And when calcium channels close, potassium again succeeds. So more potassium comes in and the membrane hyperpolarizes. So phase 3 is again by potassium and phase 4 is hyperpolarization. So why we should know about cardiac myocyte action potential and pacemaker action potential and the ions which deal about this? To know or to understand a bit more better about the class of antiarrhythmics. So we know about the Vaughan Williams classification of antiarrhythmic drugs. We basically have 4 classes. Class 1 is sodium channel blockers, class 2 is beta blocker, class 3 is potassium channel blockers, class 4 is calcium channel blockers. So where does this sodium, potassium and calcium come? If you see, sodium comes in phase 4 and phase 0 in both these action potentials. Okay, so that is the role of the sodium channel blockers. Where does potassium come here? Potassium is very important for the repolarization, whether it may be phase 1, phase 3. So in phase 3 in cardiac action potential. So there comes potassium. And where does calcium come? Phase 2 is mainly mediated by calcium. Okay. So just a short recap about antiarrhythmic drugs. Class 1 is sodium channel blockers. We have 3 categories, class 1A, 1B and 1C. We can see the drugs. 1A is quinidine, 1B is lidocaine, 1C is flecainide. Class 2 is beta blockers. So beta is the sympathetic receptor. When beta is blocked, there will be reduced sympathetic stimulation and there will be bradycardia. So all the beta blockers, so remember a few names: atenolol, esmolol. Esmolol is the IV beta blocker which is used in an emergency. It has very short half-life. Class 3 is very important drugs. They are potassium channel blockers, so amiodarone, sotalol, dofetilide, etc. Amiodarone is an important drug because it has so much of side effects. It is one drug which causes thyroiditis. Okay, think of amiodarone-induced thyroiditis. It causes corneal opacities. And class 4 is calcium channel blockers. Remember, calcium channel blockers are of 2 types: dihydropyridine calcium channel blockers. All drugs which end in dipine, nifedipine, cilnidipine, amlodipine, all these are the dihydropyridine class. Then we have the non-dihydropyridine group, which are mainly diltiazem and verapamil. The type of calcium channel blocker which is inhibited is different. We have different types of calcium channel blockers: L type, N type and T type. So dihydropyridine group inhibits L type or combined L and N type. Example, cilnidipine inhibits both L and N type. Diltiazem does not act on the L type, they act on the N type and T type. So it reduces heart rate. That's why the basic difference between these 2 types of calcium channel blockers. So just to put things together and just to keep you oriented about this tough topic, ECG is basically, it's a sum up of all the action potentials in the heart. So I told you, heart has both cardiac myocytes as well as they have pacemaker cells. So when everything gets summed up, what we get is an ECG. And see, here you can see the difference. You can see the relationship. I told you from phase 4, phase 0 depolarization is by sodium influx. Phase 2 is by calcium. So Assume that some problem occurs, or when calcium channel is blocked, there is possibility that calcium will not enter, so this phase will be prolonged, right? So that is why we can get prolongation of action potential, or in other words QRS or QT will get prolonged, right? So how can you prolong the action potential? Either you can inhibit the sodium channel, so the entire cardiac action potential will get prolonged, or you can inhibit the sodium influx or potassium efflux. You can stop the potassium efflux, so QT can get prolonged. So in other words, the phase 2 depolarization correlates with the QTC interval. So if you see the antiarrhythmic drugs, class 3, that is the potassium channel blockers, leads to prolonged QT interval. Reason is known. When potassium channel gets blocked, potassium cannot exit out of the cells, so the phase 2 gets prolonged. When sodium is inhibited, automatically the slope of the phase 0 gets prolonged, so there will be a prolongation of the QRS. So what you must know is potassium channel blockers and sodium channel blockers cause QTC prolongation. Again, we'll try to use it somewhere later. So I just brought. Now since we discussed about some electrical basics of the heart, we'll deal with some mechanical aspects of the heart. So mechanical aspect of the heart can be understood by the cardiac cycle. Please remember, atria can be taken as a separate system in the heart. Ventricles can be taken as a separate structural component in the heart, because both atria and ventricle have separate systole and separate diastole. So actually it is said atrial systole, atrial diastole, ventricular systole and ventricular diastole. But if someone says just the term systole or diastole, it actually means ventricular systole. So in ventricular systole, the duration, the entire duration of cardiac cycle is only 0.8 seconds. In that, the ventricular systole is 0.3 seconds. That is, the ventricle contracts for only 0.3 seconds and the ventricle relaxes for only 0.5 seconds. Usually people say that the laziest organ in the body is heart, because more than 50% of the time the heart relaxes. And please remember, relaxation, that is diastole, is also needs ATP, so diastole is also an active process. But colloquially it is said heart relaxes most of the time. Okay. So 0.3 seconds for ventricular systole, 0.5 seconds for ventricular diastole. For atria, only 0.1 second is the atrial systole and 0.7 second is atrial diastole. So where does this 0.1 second lie? It comes along with the last part of ventricular diastole. Last part of ventricular diastole is the stage before the ventricle goes for systole. So just before the ventricle starts contracting, the atria goes for systole and empties its entire blood into the ventricles. So we will just recap the phases of cardiac cycle. So I told you atrial systole is only 0.1 seconds. It correlates with the last part of the ventricular diastole. So what does atrial systole do? It pumps blood from the atria into the ventricles before atria into the ventricles before ventricle goes for contraction. Remember, atria, the electrical event always precedes the mechanical event. So before atria contracts, we want the atria to get depolarized. So atria has to get depolarized. So we learned that the impulses from the SA node go to the AV node. At the same time, the same impulses from SA node go to the atria and help to depolarize the atria. So first the electrical activity from SA node comes, it depolarizes the atria, and following atrial depolarization, the atria contracts. That means atrial depolarization is measured by the P wave, right? So P wave precedes atrial systole. Please remember, P wave precedes atrial systole. Now coming to the major and the most important part, which is the ventricular activity. So like P wave precedes atrial systole, we have the R wave. R wave stands for ventricular depolarization. So after the R wave in the ECG, the ventricle starts contracting. So ventricular systole has 3 stages. So one is the early systole. So what is early systole? Remember, now the atria is emptying blood into the ventricle, so the tricuspid valve and mitral valve are open. This is what happens at the end of atrial systole or at the end of ventricular diastole. So when R wave comes, when the ventricle gets depolarized, the ventricles start contracting, and when they contract, they close the tricuspid valve and the mitral valve. That's what happens initially. Now remember, both the valves are closed. That is, tricuspid and mitral valves are closed. So the AV connection is closed, and the distal valve, that is pulmonary valve and aortic valve, both are also closed. Now ventricle contracts between these two closed valves. That is called as the phase of isovolumetric contraction. Following this, what happens? The ventricle, because of raised pressure, the ventricle pushes open the AV valves and blood rushes from the ventricle to the aorta or the pulmonary valve. So that's what happens in early systole. So we have isovolumetric contraction, then the initial systolic phase and the late systole phase. So first phase, second phase, that's what is given. So after the 0.3 second is over, now ventricle should go for diastole. So what ECG wave precedes the diastole? T wave stands for ventricular repolarization or ventricular relaxation. So at T wave, what happens? After T wave, the ventricle starts relaxing. Now remember, at the end of ventricular systole, the tricuspid and mitral valves are closed, and the ventricle is pushing blood into the aorta and the pulmonary valve. So the AV valves are open now. The semilunar valves, the aortic valve and pulmonary valves are open. So at the beginning of diastole, the ventricle starts relaxing. When the pressure falls in the ventricle, the aortic valve and the pulmonary valve now close. So the ventricle relaxes between two closed ventricles. So this phase is called as isovolumetric relaxation. So we have isovolumetric contraction, which is the initial phase of systole. We have isovolumetric relaxation, which is the initial phase of diastole. So when the isovolumetric relaxation continues due to fall in pressure in the ventricles, now the the mitral valve and tricuspid valve open. So when they open, what happens? Whatever blood is present in the atria now come to the ventricle. So this is the early diastole. Now as every blood comes inside, there will be slowing. That's called diastasis. Slowing of blood, diastasis. What happens in the last part of ventricular diastole? I told you, atrial systole occurs. So the last 0.1 seconds of ventricular diastole, the atria contracts, and there is another gush of blood. So blood comes into the ventricle initially when the AV valves open, and there is a rise in blood in the last phase of ventricular diastole when the atria contracts. So this is about the phases of cardiac cycle. So just remember the 0.3 seconds of ventricular systole, 0.5 seconds of ventricular diastole. Remember, P wave precedes atrial systole, QRS precedes ventricular systole, T wave precedes ventricular diastole. Think of the 3 phases of systole and 5 phases of diastole, right? Now, since we learned something about the action potentials, the basics of cardiac conduction and basics of contractility of the heart, now it will be easy to know about the basic ECG waves. So just now we told ECG has 5 basic waves: the P wave, QRS complex, ST segment, T wave. U wave is not present in most of the cases. So the gap between starting of P wave and beginning of R wave is called as PR interval. The beginning of Q wave to the end of T wave is called as QT interval. So remember at least two intervals, PR interval and QT interval. So P wave, what does P wave stand for? As discussed, P wave stands for atrial depolarization. Atria gets depolarized from the impulses from the AC node. So P wave is atrial depolarization. Think of the mnemonic 2.5 into 2.5. It is 2.5 small squares tall, 2.5 small squares wide. So if an ECG is given, it has to be 2.5 small squares in length and 2.5 small squares in height. That is what the normal P wave is. And we have P wave, P interval, PR interval, from the beginning of P wave to the beginning of QRS complex. PR interval is the duration. So they say the normal duration is 0.12 seconds to 0.20 seconds. We know very well that one horizontal small square in ECG is 0.04 seconds. So 0.12 seconds to 0.120 seconds roughly equates to 3 to 5 small squares. So PR interval has to be 3 to 5 small squares, which means less than 3 to 5 small squares is abnormal, more than 5 small squares is abnormal. So this is about P wave, this is about PR interval. What about the QRS? QRS duration is beginning of Q wave till ST segment. So QRS duration is 0.08 to 0.12 seconds, or in short it is 2 to 3 small squares, because we discussed one small square horizontally is 0.04 seconds in a normal standardized ECG. For discussion purposes, we assume that standardization is taken normal. So that is about P wave, PR interval, QRS duration. ST segment has no measurement to remember, but it is the widow making segment. What we must note in ST segment is whether ST is elevated or ST is depressed. That's all. It's the main widow making segment. There's a discussion on that too. And what about T wave? T wave, again, we don't take the horizontal measurement. We usually say the height. Normal T wave height is 20 to 40% of the QRS complex. If it is more than 40% of QRS height, we tell it as tall T wave. If it is less than 20% of QRS height, then we call it as a flat T wave. Remember, tall T wave occurs only in two conditions. One is hyperkalemia, which is a systemic disorder or an electrolyte causing ECG abnormality. Another condition is early MI, or we say it as hyperacute MI, the stage before acute MI sets in, hyperacute MI. This tall T wave in hyperacute MI also goes by the name De Winter's sign. Okay, so tall T wave is a sign of MI. And we have flat T wave, which occurs in the opposite of hyperkalemia, which is hypokalemia. Again, why this occurs? Think of the cardiac action potential. Okay, when potassium increases in the blood or decreases in the blood, the potential difference between the cell and the blood changes. So the efflux changes, right? I'm not going into the detail, but if you think of the mechanism, you can easily understand. So why there is a tall T wave, why there is a short T wave, right? So these are some of the basic things. So why I told about all these things initially is, once you know the normal, we can discuss the abnormal in the subsequent things. So this is a normal ECG. So our aim in the exam or in a spotter is not to know the entire ECG fully. At least you should read every wave. See, this person has every wave, right? P, QRS, there is a T wave. So interpret the thing. So assume that here P wave is normal. It's in the normal height, it's in the normal duration. QRS is 2 to 3 small squares. ST is not elevated, ST is not depressed. T wave is around 20 to 40% of R wave height. Okay. If you go into the depth of ECG, there are so many other things to discuss. But for the basic thing, you should know whether the rhythm is normal, rate is normal. So just a basic approach is once you have confirmed about the name, age, the standardization, a quick ECG, you have to see the rhythm. The first thing which you have to see is rhythm. So how will you say a normal rhythm? A normal rhythm begins from the SA node, depolarizes the atria, and impulses go to the AV node. AV node delays the conduction, so we have an AV delay. This AV delay is represented by the PR interval, and the His-Purkinje system. The His-Purkinje system rapidly depolarizes the ventricle, so we get the QRS complex. Following all depolarization, the ventricular repolarization occurs before the ventricular diastole occurs. That repolarization is measured by T-wave. Right? So we should have SA node stimulation, atrial stimulation, AV nodal delay, fast conduction of the His-Purkinje system followed by atrial repolarization. And I told you about the vector duration from SA node to the ventricle. This is the direction, that is 60 degrees the axis. So we will discuss axis also shortly. So this is how a normal rhythm should proceed. So for a normal cardiac rhythm, P wave must be present. Right? So only if a P wave is present, it is a normal rhythm. Otherwise, it is abnormal. Then PR interval should be normal. Means there is a normal nodal delay, 0.12 to 0.2 seconds. If PR interval is short, what does it mean? The AV nodal delay is not happening. The impulses from the atria or the SA node is conducted to the ventricles directly without the AV node. So PR interval less than 0.12 seconds indicates there is some accessory pathway. That accessory pathway bypasses the AV node and it directly stimulates the SA node and the ventricle directly. This occurs in a condition called as Wolff-Parkinson-White syndrome. Okay? So accessory pathway, think of Wolff-Parkinson-White syndrome. Then suppose if PR interval is more than 0.2 seconds, what does it mean? The AV nodal delay is more. So the AV nodal delay is more, conduction is more, it is problematic. This occurs in a disease called as AV block. This also we will discuss in more detail shortly. So P wave should be present, PR interval should be normal, and the QRS duration should be 0.08 to 0.12 seconds. Suppose if it is less than that, there is fast depolarization. Usually we don't get it. If QRS is more than 0.12 seconds, there is a delayed depolarization of the ventricle, which means something is problematic with the ventricles. Means, what does it mean is, remember the Purkinje system is a fast conducting system. I told you the impulse travels from the SA node, AV node, his bundle to the Purkinje system. Suppose if the Purkinje system is problematic, the impulse will not go through the Purkinje system, but instead it will go from ventricle to ventricular myocyte to the ventricular myocyte. Ventricular muscle cells are poor conductors, so the ventricular muscle conducts electricity slowly than the His-Purkinje system. So if QRS duration is more than 0.12 seconds, it means the conduction system is problematic, the ventricle is conducting or generating impulse. So these are the criteria for a normal rhythm. So this is the first step which you see in an ECG about the rhythm. So the points to say a normal rhythm. Of course, PP interval should be equal, PR interval should be equal, and RR interval should be equal. So in the entire ECG, all these three intervals should be equal. So remember these 4 points to say normal rhythm. Next thing is calculate the rate. A simple formula, the rate is calculated by 300 divided by number of big squares between two RR intervals or between two R waves. I think this is more than enough. See this ECG, this is an R wave, this is an R wave. Calculate the number of big squares between two R waves, around it's 4. So 300 divided by 4 is equal to 75. So in this case the rate is 75. So after the rhythm rate, then we have to interpret every wave, whether P wave is broad or P wave is tall, whether the PR interval is short. This we have discussed in rhythm itself, whether PR is short or PR is long. Then about the QRS whether it is tall or whether it is short. Then think of the ST segment, whether it is elevated or it is depressed, and something about the P wave, whether it is tall or short, and any abnormal waves. This is more than enough for an ECG. So definitely 1 or 2 ECG questions come every year in any exam. So I think this discussion may help. Okay, so we'll discuss some pathology step by step. Now that we know the normal conduction, we know how to interpret a normal ECG. We'll discuss about the rate issues, heart rate issues. Told you the normal sinus heart rate is around 60 to 100. If heart rate is less than 60, it is called bradycardia. So bradycardia can usually be physiological or pathological. When it is pathological, we usually say the term bradyarrhythmia. Pathological bradycardia is called bradyarrhythmia. So nothing much to discuss here. So what are the causes of sinus bradycardia? Remember, sleep causes bradycardia, hypothyroidism causes bradycardia, hypothermia, hypoxia. These are some conditions which cause bradycardia. What is sinus bradycardia? Rhythm is normal, but only the rate is low. So it is sinus bradycardia. These are some of the conditions. Remember, vagal reflex, coughing also will cause reduced. But all these are some of the physiological conditions. There is no disease in the heart, but some systemic disease or a normal condition is causing bradycardia. This is called physiological sinus bradycardia. Of course, some diseases like some medicines like beta blockers, non-dihydropyridine calcium channel blockers, and some anti-arrhythmic medicines, and some diseases like old age, etc. They cause pathology or they cause some damage to the conducting system or to the SA node. So in that case, it is called as sinus nodal dysfunction. So whenever there is a bradycardia, ECG shows a sinus rhythm, always rule out the physiological causes like sleep, hypothyroidism, hypoxia, hypothermia, increased intracranial pressure, that is Cushing's reflex. All these things should be ruled out. Once all these things are ruled out, think of other causes also. Think of drugs. Once drugs are ruled out, when there is no reversible cause, we always label it as sinus nodal dysfunction. So how does sinus nodal dysfunction manifest? The P wave does not generate a rhythm. So there can be something called as sinus pauses. A normal heart rate or a normal rhythm will be there. Suddenly P wave will be absent. Because there is no SA node stimulation, P wave will be absent. So that is sinus pauses. So patient can have syncope and fatigue. So this is about sinus nodal disease. So this can come as a clue. Now about AV block. So when SA node is problematic, it causes a bradyarrhythmia. What if the AV node is problematic? When AV node is problematic, there may or may not be problems with rhythm. But definitely, I told you, AV node, the function is to delay conduction. When AV node is problematic, the conduction delays further. Sometimes the conduction may not be there from SA node to the His-Purkinje system. So we have 3 types: first degree, second degree, and complete AV block. First degree AV block is only prolongation. So already told, normal PR intervals 0.12 to 0.2 seconds. So the PR interval gets prolonged, but there is no dropping of beats. So everything is conducted, but only PR is prolonged. So see here. Here, if you this is the P wave. So from P wave to the QRS, you can very well see it is around 6 small squares, right? So we can very well see here PR is prolonged, but all of the other things hold good, right? P wave is present everywhere. PR is prolonged but equal. RR interval is equal. All the waves are present. So it is only a first degree AV block. Second degree AV block, there is some drop in a beat. Second degree AV block is of 2 types. One is called as Wenke-Bach phenomenon or Mobitz type 1. There is progressive prolongation of PR interval and one wave drops. So see this regular irregularity here. P wave is of a particular length here. Here, the next wave, PR gets prolonged. PR gets even prolonged, and suddenly there's a drop. So progressive rise in PR interval followed by a block. So this is Wenckebach phenomenon. Wenckebach type 2, there is a drop in beat, but there is no progressive prolongation. See here, P wave is there, QRS is there, T. P wave is there, QRS is there, T is there. There is no progressive prolongation of PR interval. In fact, PR interval is normal. But see, there is a P wave, which means SA node has stimulated, atria has been stimulated. But there is no QRS, which means the stimulation of the SA node or stimulation from the atria does not reach the ventricle, which means AV node has blocked that conduction. So this is Mobitz type 2 second degree AV block. This is very classic. See, we can see a P wave here. Whatever is given in arrow is a P wave. There are multiple P waves. See, there are multiple P waves, but everything is not getting conducted. So atria is depolarizing normally. But nothing is getting conducted to the ventricle. So what does the ventricle will do? We already discussed that ventricle can generate its own rhythm at the rate of 40 per minute. So here the ventricle is generating its own rhythm. See, the QRS is prolonged, so it's a ventricular rhythm. QRS is prolonged, it's a ventricular rhythm. So the ventricle is generating its own rhythm at 40 per minute. So the atria is generating its own rhythm, ventricle is generating its own rhythm, but they don't come together. So this is called as AV dissociation. So if such an ECG is given, just you have to pick up. There are multiple P waves, there are multiple R waves. The R wave rate or the ventricular rate is 40 per minute, but the atrial rate is not getting transmitted to the ventricle. This is complete heart block. So this is what we just discussed. So what are the causes of AV block? Again, same thing like we approached sinus bradycardia. Usually sinus bradycardia, many causes are physiological, some cases are pathological. But AV block is usually considered as pathological. Again, we have to rule out some drugs. Coronary ischemia. Remember, inferior wall MI or right ventricular wall MI causes AV blocks. Some infections like myocarditis, Chagas disease can cause. And mostly it's a age-related fibrosis or trauma to the conducting system. And think of maternal lupus, congenital AV block. Mother having SLE, baby will have AV block. Some are idiopathic. Okay, so other things you can do. Some muscle dystrophies can cause heart blocks, AV blocks. Okay, so this finishes our discussion on bradyarrhythmia. So bradyarrhythmia, only two diseases we discussed. One, a sinus bradyarrhythmia. So it is usually physiological or related to drugs. If it is pathological, we call it as sinus nodal disease. How does it manifest? I told you. No P wave will be there. The next condition is AV block. We have 3 degrees. First degree, where there is only a prolongation of PR interval. Second degree, there is a dropped beat. So Mobitz type 1 AV block, there is progressive prolongation of PR interval and a dropped beat. And Mobitz type 2, there is a dropped beat without progressive prolongation and the classic complete heart block. Complete heart block and Mobitz type 2 heart block are dangerous because they usually has symptoms. So some questions can come on these. Now how will you approach tachycardia? So like we approached bradyarrhythmia, we can approach tachycardia or tachyarrhythmia in the following. Always the first thing is rate is more than 100 but rhythm is normal. We can call it as sinus tachyarrhythmia or a sinus tachycardia. Like we discussed in bradycardia, rate is less than 60, rhythm is normal, it is called sinus bradycardia. Only when ECG changes occur, When a P wave is dropped, we call it a sinus nodal disease or a sinus pause. When PR is prolonged, we call it as AV nodal block. So likewise, when heart rate is more than 100 but rhythm is sinus, we call it a sinus tachycardia. Usually sinus tachycardia is physiological. So like it can occur in fever, it can occur in hyperthyroidism, it can occur following exercise. So following any stimulation or emotion. Okay, so this is sinus tachycardia. Of course, sinus tachycardia can be pathological. Like without any reason, if the patient has tachycardia, you always think of autonomic neuropathy, like in diabetes. So the name is given for that, POTS, orthostatic tachycardia syndrome. So we are not discussing that here. So sinus tachycardia usually is physiological. Only few diseases are associated. Can you recognize this ECG? Whenever you get a disease process, a patient is tachypneic with sinus tachy, apart from his disease, like he may have fever and tachycardia, he may have pulmonary edema and tachycardia. Apart from that, one disease typically causes sinus tachycardia without any lung signs. Right? Patient is having a wheeze and tachycardia, obviously it is bronchial asthma exacerbation. Patient is having sinus tachycardia without any lung signs, always we have to rule out this condition. So this condition is pulmonary embolism. So try to pick up this clue. Patient like post-op case who had a DVT or a leg swelling, suddenly presents with breathing difficulty, desaturation. Okay. So what is given in the ECG is the classic S1, Q3, T3. S1 is, we can see there is S wave in lead 1, and see V3, there is T wave inversion, and you can see there is Q wave in lead 3. So S wave in lead 1, Q wave in lead 3, and T wave inversion in lead V3 is called as S1, Q3, T3. This is the most characteristic or the most typical finding in pulmonary embolism, but still the most common finding remains sinus tachycardia. Okay. Now we have a risk scoring for pulmonary embolism. Usually DVT leads to pulmonary embolism. So this is the Wells score. There's a Wells score for DVT and there's a Wells score for pulmonary embolism. So even if you don't remember the score, please remember presence of cancer, presence of unilateral calf swelling, most of the, and there is a bedridden, a recent major surgery less than 3 months, and if they are bedridden for more than 3 days and there is paralysis, it's a risk for DVT. Just note the clues here. And pulmonary embolism, there is similar. There is a history of DVT. Okay, there is heart rate more than 100. That is sinus tachycardia is one important finding. Again, history of immobilization more than 3 days and surgery in the last 1 month. Prior history of DVT, hemoptysis, and malignancy. So if any of these clues is present, always in the question or in the original clinical scenario, you can diagnose pulmonary or suspect pulmonary embolism. How will you proceed? If there is a doubt, we can do D-dimer. D-dimer is not the investigation of choice. For DVT, the investigation of choice will be Doppler scan, venous Doppler. And to prove pulmonary embolism, we do CT pulmonary angiography. It can visualize the clot. Where D-dimer is useful is to risk stratify. Suppose if you put the score is less. In that case, you can do D-dimer. If D-dimer is high, then you can go about with CTPA or venous Doppler. If the risk is high, that is if the score is high here, directly you can go for CTPA. Sometimes you may be given an X-ray. So we have two important signs in this X-ray in pulmonary embolism. See, in this X-ray, this is the cardiac shadow. If you closely see, what you see here is the left pulmonary artery, which divides. Likewise, here also you should get the right pulmonary artery. But this is very well visible, but this side it is not that much visible. Also, you can just compare the pulmonary vasculature in left side. Here you can very well see the white color branching pattern, but here it is not seen. So this is a pulmonary oligemia. In pediatric x-rays, this oligemia and hyperemia is very important to diagnose different congenital heart diseases. In adults, a unilateral pulmonary oligemia is called as Westermarck sign. What is Westermarck sign? Cutoff. There's a cutoff of the pulmonary artery. What is this now? A wedge-shaped or a triangular opacity. This is called as Hampton sum. It occurs due to pulmonary infarction. This pulmonary infarction leads to hemoptysis. So one presentation of pulmonary embolism is hemoptysis. There are other signs like Palla sign, etc., but these are two very important signs. Westermarck sign is pulmonary artery cutoff. Hampton sign is pulmonary infarction causing a hump-like opacity. So ECG, the common finding is sinus tachy. Typical finding is S1Q3 T3. The pathogenesis is ventilation perfusion mismatch. Presentation is breathing difficulty with severe hypoxia, and lung signs are normal. There is no lung signs. So when discussing about sinus tachycardia, you just remember about pulmonary embolism. Now coming to the other tachycardias. Now how will you approach the tachycardia, right? One simple way, when a tachycardia is there, when heart rate is high or ECG shows high heart rate, there is a tachyarrhythmia. Always you have to see if it is not a sinus tachycardia, you see whether the QRS is narrow or if the QRS is broad. So if the QRS is narrow, that is if the QRS duration is 0.08 to 0.12 seconds or 2 to 3 small squares, we call it as narrow. If it is more than 0.12 seconds or more than 3 small squares, we call it as broad. Please remember, QRS narrow means the conduction is going from the AV node through the His-Purkinje system into the ventricles. So narrow complex means definitely the rhythm is originating above the ventricle. So where it may originate anywhere. It can originate from SA node, AV node, or any tissue in the atria. But wherever it originates above the ventricle, it comes back to the His-Purkinje system and stimulates both the ventricles. If QRS is broad, what does it mean is the conduction does not go through the His-Purkinje system. Instead, it goes through the slower ventricle to ventricle myocyte transmission. Means the impulse is originating from AV node or below. Okay, so we call it as a ventricular rhythm or junctional rhythm also. AV nodal junction also gives rise to the same. So this is how you differentiate. Whenever there is a tachyarrhythmia, classify whether it is a narrow complex tachyarrhythmia or a broad complex tachyarrhythmia. Now, if there is a narrow complex tachyarrhythmia, how can you classify? See, when a complex is supraventricular, it can originate from the ventricle, or there are some re-entrant pathways. Re-entry is one mechanism of tachyarrhythmia. So narrow complex tachyarrhythmia divide whether the atrial rate is regular or irregular. We know the classic definition. When there is a supraventricular tachyarrhythmia with irregular heart rate, it is usually atrial fibrillation. The other DD is multifocal atrial tachycardia. Suppose if it is regular, we have three differential diagnoses. One is AVNRT, and we have AVRT, AV nodal reentrant tachycardia, AV reentrant tachycardia, and we have FAT, focal atrial tachycardia. So we have focal atrial tachycardia, AV nodal reentrant tachycardia, atrioventricular reentrant tachycardia. We have the atrial fibrillation, atrial flutter, multifocal atrial tachycardia. Of this, atrial fibrillation and multifocal atrial tachycardia are irregular. Even if you don't remember multifocal atrial tachycardia, it's not an issue. Remember, AF is narrow complex tachycardia, which is irregular. All others are narrow complex tachycardia, which are regular. We'll see them one by one. Now, can you interpret this ECG? Definitely it is tachycardia. You can very well see heart rate is around 200 or 300. Now try to find out the rhythm. Can you make out a definite P wave? Clearly no, right? So there is no P wave. No P wave means the atrium is not depolarized, or the impulse is not a sinus rhythm. It's not originating from sinus. So it's a tachyarrhythmia, no P wave. What about the QRS complex? Always in tachyarrhythmia you have to see if it is narrow complex or broad complex. So it is narrow complex. Means it is a supraventricular tachyarrhythmia. Is it regular or irregular? Definitely it is regular. So this is a regular narrow complex tachycardia with rate around 200. So P wave is not seen. So this is actually AV nodal reentrant tachycardia. Re-entry is one mechanism of tachyarrhythmia. We are not discussing that in detail. There is something called as retrograde P wave. Retrograde P wave is the ventricle gets stimulated first, then the atria gets stimulated. If you see, one unusual wave is there. See, one wave comes after the QRS complex, one dip comes after the QRS complex. Again in V1, one wave comes after the QRS complex. So they are the actual retrograde P waves. So if you are confused, leave it off. Regular narrow complex tachycardia is usually AVNRT. We have another tachycardia. See here again, it is a narrow complex tachycardia, no P wave, and it is regular. So since it is not a P wave, we diagnose it as AVNRT, but actually this is a case of AVRT because the P wave comes after QRS complex, but it comes a little later than AVNRT. Okay, the P wave comes a little later than AVNRT. So they usually calculate the R wave to P wave interval. If you are very much confused, you need not break your heads. Just remember the most common regular narrow complex tachycardia without P wave is AVNRT. AVRT is also the same, but AVRT usually has a predisposing disease, which is Wolff-Parkinson-White. We already discussed Wolff-Parkinson-White is one disease causing accessory pathway. Accessory pathway is it's a pathway connecting SA node to the ventricle directly without going to the AV node. When such thing happens, what happens? AV node usually delays the conduction. So here conduction is faster. So when conduction is faster, we know very well that PR wave shortens. PR wave will be less than, PR interval will be short. PR interval will be less than 0.12 seconds. So we have a triad in Wolff-Parkinson-White. Hope you can make it out here. PR interval is short. Okay. Short PR interval. Can you see a slurring of wave initially? After the P wave, there is a slurring. So why that slurring? It's a slurring. This slurring is called as the delta wave. And third, see, the QRS is broad here. It is more than 3 small squares. Why QRS is broad? Because the conduction here does not occur through the His-Purkinje system. The connection is between SA node and the ventricle. So since there is an accessory pathway, it bypasses the AV node, we get a short PR interval. There is a slurring initially because of the rapid conduction, and QRS is broad because the conduction is through the ventricles. So this is the classic Wolff-Parkinson-White syndrome. If there is a background of Wolff-Parkinson-White syndrome, they usually develop AVRT. If the background ECG is usually normal, they can develop AVNRT. So usual clues in exams or post correction you can get. So AVNRT and AVRT are usually managed in the same lines. Once management is done, patient gets corrected. If the underlying baseline ECG is normal, see this is a baseline relatively normal ECG, then it is usually AVRT. If there is an underlying pre-excited syndrome like Wolff-Parkinson-White, we call it as AVRT. So how will you treat AVNRT? First thing is vagal maneuvers. So all these are vagal maneuvers. Breathing against pressure, Valsalva. What is Valsalva? Breathing against a closed glottis is Valsalva. So blowing into a syringe, blowing against a closed mouth. All these are Valsalva. So raising the leg, carotid sinus massage, it's commonly done. So these are the vagal maneuvers which are done. So what vagal maneuver does? Vagal stimulation, we discussed, it causes AV block. When AV blocks, it reduces conduction from the atrium to the ventricles. So it will help very well in AVNRT. What is the next step? Adenosine. Adenosine, like esmolol, is a drug with a very short half-life. So it is given. So some 3 doses can be repeated. So if not, we have some AV blockers. So AV blockers, remember A, B, C, D. A already it is mentioned, adenosine. So the first drug which we give in AVNRT is adenosine. Next is we have beta blockers. So one beta blocker which is used in emergency is esmolol. Esmolol is again a drug with a very short half-life. Then we have calcium channel blocker. Already discussed calcium channel blocker. We have dihydropyridine, non-dihydropyridine. So the non-dihydropyridine calcium channel blockers like diltiazem and verapamil are available as IV. They are usually given. And D is for digoxin. So these drugs are called as AV blockers. So in AVNRT or in other supraventricular arrhythmias, AV blockers can be tried. So AVNRT, again we are giving these AV blockers, but the baseline ECG will be a pre-excited ECG causing Wolff-Parkinson-White. Suppose there is a tachyarrhythmia, a narrow complex tachyarrhythmia which is regular, but there is a P wave. So very well this looks like a sinus tachycardia, but if the P wave is not a sinus one, so there are some specific characters of a sinus P wave. That is, if the rhythm is originating not from the SA node but from a atria, it is called as focal atrial tachycardia. So we know, if you want to know the basics, normally lead 2 and lead 3 will have the tallest P wave, but here it may be different. There are different morphologies of P wave. There may be inverted P wave, there may be very tall P wave, there may be tall P wave in lead V1. So need not break your heads, just understand there is an entity called as focal atrial tachycardia. What is atrial flutter? You just see this important pattern here, sawtooth pattern. So multiple atrial waves but one QRS. So like 3 atrial wave for one QRS complex. There may be 3 atrial waves or 2 QRS complex. So 3 in 1 conduction or 3:2 conduction. This is atrial flutter. Suppose one MCQ may come, or if someone asks you atrial flutter, the mechanism, here again it is re-entry. It is called KO tricuspid isthmus re-entry. Just think it as a one-liner. Atrial fibrillation, our classic one which we had discussed. Narrow complex tachycardia, no P waves, but this one is irregularly irregular or irregular. In V1 you can very see the undulating baseline or fibrillatory waves. Any arrhythmia, if you are not able to make out, please see V1 where you can get fibrillatory waves or the undulating baseline. So narrow complex tachycardia without P wave, if it is irregular, think of atrial fibrillation. Like atrial fibrillation is the most common arrhythmia overall, most common clinically significant arrhythmia overall. That's why it's given so much of importance. So usually any condition causing dilated atrium, we are going to discuss it in short. Any condition causing dilated atrium, usually valvular heart disease, eventually causes atrial fibrillation. Or some drugs like thyroxine or hyperthyroidism or alcohol, etc. can cause. How will you treat? First thing, rate control. Second thing, rhythm control. Third is cardioembolic stroke prevention. Sometimes the order comes in differently. Rate control is most important. Next comes stroke prevention. Rhythm control comes last actually. So the types of AF are based on duration, paroxysmal AF. If AF is less than 7 days duration, like patient was normal, it comes only for 2 days, it is paroxysmal AF. Then we have persistent AF. Seven days to 1 year is called persistent AF. Long persistent AF, so duration is more than 1 year. We have something called as permanent AF. Patient is having some valvular heart disease, patient always indefinitely has AF. So we cannot cure permanent AF. So management varies. Like patient has only AF for less than 48 hours. In that case, you can cardiovert. Cardiovert is rhythm control. So you can either do electrical cardioversion or you can do pharmacological cardioversion with drugs like ibutylite. But once it crosses 48 hours, what happens is, because the atrium fibrillates, it has a high chance of clot formation in the left atrium or left atrial appendage, and it can go for cardioembolic stroke. So if AF is more than 48 hours or if duration of AF is not known, you must not do rhythm control. That's why you are supposed to do rate control. So in most MCQs, they test this by giving the duration. They ask you to do rate control. So how do you do rate control? Again, our ABCD. Here the A is not adenosine. Adenosine does not work in atrial fibrillation. We can give amiodarone. B for beta blockers. C for non-dihydropyridine calcium channel blockers, and D for digoxin. And cardioembolic stroke prevention. So who all do you give cardioembolic stroke prevention? We have a risk scoring. CHAD-VASc score. So C is congestive heart failure. H is hypertension. A is age more than 74. D is diabetes mellitus. S is stroke. V is any vascular disorder or a vasculitis. The next A is age between 65 to 74. SC stands for female category of 6. So everyone is given 1 point except age more than 74 and stroke. So based on the clinical scenario given, you can calculate the CHAD-VASc score. If the score is 0, there is no need to anticoagulate. There is no risk of cardioembolic stroke. If the score is more than 2, more than or equal to 2, we must anticoagulate. 1 is doubtful. One older guidelines told that we can give aspirin, but now it is universally said if there's an additional risk factor, you can always anticoagulate. So more than 2 or equal to 2, definitely anticoagulate. So how will you anticoagulate? Anticoagulation, we have heparin or low molecular weight heparin, or we have fondaparinux. So what are these drugs? These drugs are large compounds which inhibit factor 2 and factor 10. There are some next steps. There are newer drugs that are called as novel oral anticoagulants or directly acting oral anticoagulants. So heparin actually binds with factor 2, it actually binds with antithrombin 3 and it indirectly inhibits factor 2 and 10. But we have Novax or Dovax which directly inhibit either factor 10 or factor 2. Factor 10 gets activated to factor 10A and it stimulates factor 7, then it stimulates factor 2. Factor 2 is also called as prothrombin. Prothrombin becomes thrombin. Thrombin activates fibrin clot. That is how the clotting mechanism comes. Factor 10, factor 7, factor 2 becomes 2A. 2A is thrombin. It activates fibrinogen to fibrin. Factor 10 is the common pathway where intrinsic mechanism acts, extrinsic mechanism also acts. If we have chance, we may discuss it later. Just understand that factor 10 is the common pathway and factor 2 is the final pathway. So factor 10A is written in English as XA. So when XA is banned, the drugs like Apix are banned, Rivarox are banned, Adox are banned. So XA, BAN is factor 10A inhibitors. Factor 2 inhibitors, I already told you, factor 2 is prothrombin, it gets converted to thrombin. So thrombin antagonist. So remember the drug dabigatran. Dabigatran is a oral thrombin antagonist. We have other injectable forms also, at least these are very commonly used. Okay, so either heparin is used or Novax are used, or we have VKA, vitamin K antagonist. Vitamin K dependent clotting factors are factors 2, 7, 9 and 10. So when vitamin K is inhibited, these clotting factors are not formed, so anticoagulation occurs. So we have warfarin, acinocomarol, etc. Understand about the term bridging. Vitamin K antagonist, that is warfarin, inhibits factor 2, 7, 9, 10. Also it inhibits protein C and protein S. So 2, 7, 9 and 10 are structures in or proteins in clot formation. Protein C and protein S are anti-clotting factors. So actually clotting and anti-clotting both are inhibited. But what is the time duration? Protein C and protein S are inhibited initially. Factor 7 is, 2, 7, 9 and 10 are inhibited later. So in the initial 2 days, since the anticoagulant proteins are inhibited, even after giving warfarin, there is a prothrombotic tendency. Remember, in warfarin, the first 2 days, there is a prothrombotic tendency due to inhibition of protein C and protein S. That is the reason why usually we get the purple glove syndrome or extensive clots or necrosis in the initial 2 days. So before heparin is switched over to warfarin, there is something called bridging. We usually give heparin and vitamin K antagonist together for at least 2 days, and then only we should stop heparin. We should stop heparin when the APTT becomes the target level, which is more than 2 times the upper limit of normal. So this is bridging. Question may come, in Novax or Dovax, bridging is not needed. And for vitamin K antagonist, to know whether the anticoagulation appropriate, we had to measure INR, PT-INR. So normal INR is less than 1. More than 2 is taken as therapeutic. In some cases, it is taken as more than 2.5. So INR monitoring is needed in vitamin K antagonist, whereas the monitoring is not needed in Novax. The antidote for vitamin K antagonist is obviously vitamin K. We can give FFP or cryoprecipitate. There are some specific reversal agents available for Novax or Dovax. Okay. So this is about cardioembolic stroke prevention. Rhythm control, already told, it is either by electrical cardioversion or pharmacological cardioversion, done only when AF is less than 48 hours duration, or when the duration is unknown, we always anticoagulate for 3 weeks before controlling rhythm. So this is about AF and its management. We must know everything because it is commonly done. So please remember the Chadwick score. Okay. Multifocal atrial tachycardia, it is also an irregular rhythm, not usually seen in questions, but just for understanding sake. See here, is there tachycardia? Yes. Heart rate is around 300, so there is tachy. Whenever there is tachyarrhythmia, which is non-sinus, see whether it is narrow complex or wide complex. This is a narrow complex tachycardia. Is it regular or irregular? Definitely you can see some irregularity. Some spaces are small, some are large. So it is an irregular narrow complex tachycardia. Next thing, see the P wave. Of course, P wave is present, but every P wave is different, right? See, this P wave is small, this is large, here it is very small. So there are multiple types of P wave. So this is multifocal atrial tachycardia, usually seen in COPD. We don't see or discuss it usually, but I just kept it just for interpretation sake. Okay, so whenever ECG is kept, we understand that it is tachycardia. See whether it is a sinus or a non-sinus rhythm. We can easily pick up sinus tachycardia. If it is not a sinus rhythm, narrow complex or wide complex. If it is narrow complex, see whether it is regular or irregular, and hence you can make a diagnosis. Now, since narrow complex tachyarrhythmias are done, we will come to wide complex tachyarrhythmias. Wide complex tachyarrhythmias means the arrhythmia originates from the ventricles. So you can very well see here. Definitely that is a tachyarrhythmia. If you divide 300 by the number of big squares, heart rate is around 150 per minute. So it is a tachyarrhythmia. Definitely it is wide complex. So it's a wide complex tachyarrhythmia. So is it regular or irregular? It is regular. So what is the diagnosis? It is ventricular tachycardia. So ventricular tachycardia, there are many ways of classifying. So it may be non-sustained VT or sustained VT. I think it is useful to classify ventricular tachycardia as monomorphic VT and polymorphic VT. It's like multifocal atrial tachycardia only. See, all the QRS complexes are nearly same. So it is a monomorphic VT. What is this? So this also looks like VT, right? So there is tachy, there is wide QRS complex. So this looks like a VT, but if you see carefully, the rate is not actually more than 100. The rate here is around 90 to 100. So it is called as accelerated idioventricular rhythm. I kept this ECG intentionally here because I want you to understand the concepts here, right? So obviously we picked up that this is a wide complex. There is no P wave, so it is a ventricular rhythm. But you forgot to calculate the rate here, right? The rate is not more than 100. Only when the rate is more than 100, we call it as a tachyarrhythmia. Here the rate is less than 100. But since it is it's still wide complex. So actually it is a junctional tachycardia. Sorry, it's actually an accelerated idioventricular rhythm. Remember we discussed about ventricular rhythm, and the actual ventricular rate has to be 40. So this is originating from ventricle, but the rate is 70 or 90. So it's called as an accelerated idioventricular rhythm. It is usually seen post cardiopulmonary resuscitation. So this has been asked previously, that's why I kept this. So don't confuse that this is a VT. Please calculate the rate first Only then you should proceed in interpreting. This is an accelerated idioventricular rhythm. Yes, a few quickies. So what is this? Definitely tachy, definitely white complex. Rate is around 200, more than 200. So no P wave, only QRS is there. Uniform, so it's a monomorphic VT. What they have pointed out is there is something called as AV dissociation. We have discussed AV dissociation in bradycardia, where it comes in complete heart block. AV dissociation in tachycardia comes in ventricular tachycardia. See, this is a P wave. It comes unrelated to the origin of QRS complex. What is this? This is also monomorphic VT. This is also monomorphic VT. Textbook says this is taken from Harrison. It gives that it's a sinusoidal VT of hyperkalemia. Remember, hyperkalemia, initially we discussed that tall T wave is one feature of hyperkalemia. But tall T wave is the initial feature of hyperkalemia. Like when hyperkalemia progresses, it can become sinusoidal like this. This is a sinusoidal wave. Now what about this? This is clearly not monomorphic VT. This is VT of course, but the waves are not uniform. So this is a polymorphic VT. Usually monomorphic VT originates from one site in the ventricle. So it usually occurs post MI or from a scar. So monomorphic VT usually occurs post MI or from a scar. But polymorphic VT, also called as torsionis D pointus, always has a predecessor. Like we discussed, AVNRT comes from a normal ECG. AVRT comes from a pre-excited ECG or Wolff-Parkinson-White. Likewise, torsionis D pointus always comes from QT prolongation. QTC is nothing but corrected QT interval. It is given by many formula. Remember Besset's formula, QT divided by square root of RR interval. Even if you don't understand this formula, I'll show you later how an easy way to see how QT is prolonged. So this is actually QT prolongation. Okay, so baseline ECG showing a QT prolongation, it breaks into an arrhythmia which is torsionis D pointus. This looks like torsionis D pointus. It's actually ventricular fibrillation where we do not discern the ventricular waves very easily. So how will you manage? Managing arrhythmias is very simple. Always try to understand whether the patient is hemodynamically unstable or hemodynamically stable. Because if they are hemodynamically unstable, the only thing which you have to do is shock or defibrillate. So in our question discussion series, we are discussing about post-cardiac arrest rhythms. So post-cardiac arrest rhythms may be pulseless electrical activity or asystole, which are not shockable. Then we had pulseless VT and ventricular fibrillation, which are shockable. So patient is unstable, either give shock or defibrillate. Even for AF, if they are in sick or hemodynamically unstable, we can give a shock. Like we discussed, electrical cardioversion. Suppose patient is stable, then in that case we have to give drugs. So usually some drugs like lidocaine, amiodarone, etc. are given in ventricular fibrillation. And since QT and in torsionis D pointus, the drug will be magnesium sulfate. Hypomagnesemia is one cause of QT prolongation. Magnesium has antiarrhythmic properties. In TDP, magnesium sulfate is given, or in QTC prolongation also it is given to prevent arrhythmia formation. But once they go for TDP, if they are unstable, we have to shock or defibrillate. I'll tell you one simple technique to identify QT prolongation. First calculate RR interval. Then you draw a line QT interval. If the normal QT interval is less than 50% of RR interval. But here you can see the QT interval is more than 50% of RR interval, which means there is a QT prolongation. This is the simplest way. Maybe I'll show you another ECG. Draw RR interval, draw QT interval. So QT interval is usually 50% of RR interval. If it is more than 50%, it is QT prolongation. Here it is around 50%. So maybe you can see in another lead. So R wave, QT is here. So here again QT is prolonged. We'll go to the normal ECG which we saw earlier. See R wave, QT is here. See here QT interval is less than 50% of RR interval. So this is a normal QT. So this is the quickest tip to identify QT prolongation. Of course, there are formula like Besset's formula to calculate. So QT prolongation is again a very important concept because it breaks down into torsades, depointers. So there are some congenital conditions like long QT syndrome 1, long QT syndrome 2, long QT syndrome 3. These syndromes cause sudden cardiac death. LQTS2 causes sudden cardiac death during sleep. LQTS1 causes sudden death during emotion or exercise. LQTS3 causes death during emotion. So this was one important question. So these are potassium channel mutations or sodium channel mutations. So we had discussed in the electrolytes and ECGs. When potassium channel mutation is there, what happens to QTC? The phase 2 gets prolonged. So there will be QT prolongation. But even more common than congenital QT prolongation, we have electrolyte abnormalities. Hypokalemia causes prolonged QT. Hypomagnesemia causes prolonged QT. Hypocalcemia causes prolonged QT. So 3 hypos: hypokalemia, hypomagnesemia, hypocalcemia. There are many drugs which prolong QT interval. We discussed in antiarrhythmics, class 1 and class 3. Class 1 are sodium channel blockers. Class 3 are potassium channel blockers. Both cause prolongation of QT. Self-explainable. And we have many drugs like macrolides, fluoroquinolones, cotrimoxazole, antimalarials, antifungals, antipsychotics. So many drugs can prolong QT interval. And we have hypothyroid, hyperparathyroidism, pheochromocytoma, etc. Right. So since we started with bradycardias, we discussed about tachyarrhythmias, and while discussing TDP, we had come to QT prolongation. And we'll finish off the electrolyte imbalances and ECG also. So this is the hypokalemia ECG. We discussed when hypokalemia is there, T wave becomes flat. There may be U wave formation. U wave may be normal, but it can occur in hypokalemia. What happens in hypothermia? You can see one slurring here. In Wolff-Parkinson-White, we saw a slurring of wave before QRS complex. That was called as delta wave. Here we are seeing a slurring of wave after QRS complex. So it is called as epsilon wave. E comes after D. So it's called epsilon wave. So it's called Osborn wave of hypothermia. Okay, so this is Osborn wave of hypothermia. Amiodarone toxicity. And tricyclic overdose. Tricyclic overdose causes QT prolongation. See, RR, QT is more than 50% of RR interval. Subarachnoid hemorrhage causes T wave inversion. It's called as cerebral T waves. Amiodarone is class 3 antiarrhythmic, potassium channel blocker. It also causes QT prolongation. Okay. So see, hypocalcemia causes QT prolongation. The opposite, hypercalcemia causes shortening of QT. It's very short. Okay. This ECG is actually hyperkalemia ECG. You can see the tall T wave. Only two conditions cause tall T wave. One is hyperkalemia. Another is hyperacute MI, which is De Winter's sign. So till now we had discussed about the basics of cardiac cycle, cardiac rhythm conduction, basics of ECG, the cardiac action potentials, the various ions, and how they cause changes in ECG. And we discussed about bradycardia and bradyarrhythmias, and we discussed tachycardia and tachyarrhythmias and how to manage them.